of intracranial hemorrhage, primarily spontaneous intracranial hemorrhages.
I'm not doing this job here. This is Dr. Stuart Levy. Okay, well, not everybody is from most of our job, but we were talking about this later. I thought you've been here 10 years and this time flies. Dr. Levy, from Arkansas, he did his residency here. He's now in his 16th year at St. Anthony's. And really, he was the second of what is now our coroner, so he looked after John Nichols. Or were you?
Yeah, Nichols started the practice in 1994, and I joined him in '96.
So, yeah, he's, he'll be grandfather then soon. Okay. So, thanks, Stuart.
Yeah, you only wish it had been 10 years.
Well, this didn't seem like 20.
Yeah, feels like 50. All right, so we're going to talk a little bit about spontaneous intracranial hemorrhages, and this will lead into Dr. Larson's talk on the management of vasospasm, because we'll finish up primarily with subarachnoid hemorrhage. And let's see if I can figure out how this thing works. Looks like we're going to go this direction. So, the spontaneous intracranial hemorrhages can be divided up, of course, into intracerebral hemorrhages, which are often associated with intraventricular hemorrhage as well. Rarely will you see a truly isolated IVH, but you can have one if it bleeds just from the choroid plexus, for example. And then we'll talk mostly about subarachnoid hemorrhage. And actually, we're not going to talk about subdurals or petechial hemorrhages, really. And the causes of spontaneous intracerebral hemorrhages and intracranial hemorrhages of all types include hypertension is probably the #1 cause, as most of you know. And obviously, you have a lot of hypertensive patients in our country now, and so we're seeing a lot of spontaneous intracerebral hemorrhages. And as a developing stroke center and a referral center for so many different hospitals, we kind of get a distillation of the worst neurologic catastrophes. So we have a disproportionately high percentage of hemorrhagic strokes compared to ischemic strokes. Overall, the incidence, the breakdown is that about 10 to 15% of strokes are hemorrhagic, but here at St. Anthony's, it's about 25 to 30% of our strokes that are admitted are hemorrhagic because we get so many transfers in from other hospitals. Obviously, the minute the ER doc sees blood in the head, they change their underwear and then get on the phone to find a hospital where they can send the patient just to get them out of their hospital. They want them somewhere where there's a neurosurgeon, even though the vast majority of these don't really require surgical intervention. And the medical management of these patients is really the critical aspect of their care, as we'll see. And so we're going to talk about that in a minute. And then amyloid angiopathy is another significant cause of spontaneous intracerebral hemorrhages that really is largely unrecognized by those outside the neuroscience specialties. And typically these are lobar hemorrhages as opposed to the deeper basal ganglia hemorrhages and brainstem hemorrhages that you see from hypertension. And then, of course, there's the vascular malformations. This is what most people think about when they think about spontaneous hemorrhages, but they're not the majority of the cases. Cerebral aneurysms, of course, result primarily in subarachnoid hemorrhage. AVMs can give you parenchymal, subarachnoid, subdural, intraventricular. They can hemorrhage pretty much anywhere. And cavernous malformations usually result in parenchymal hemorrhages. Other causes without any other underlying problems just include coagulopathy. We have more and more patients on Coumadin and Plavix and Pradaxa and all the fun new anticoagulant medications, and it's a growing population of patients. It's definitely job security, but we do wish that fewer people would bleed into their brain on these drugs. Tumors will sometimes hemorrhage into the brain spontaneously as well. And then, of course, you can have hemorrhagic transformation of ischemic infarction spontaneously or following administration of thrombolytic therapy. And venous infarcts particularly have a high rate of hemorrhagic transformation. Dural venous sinus thrombosis, cortical vein thrombosis often results in hemorrhagic infarcts because of the congestion and impaired venous outflow. So this is a classic example of hypertensive basal ganglia hemorrhage. You guys have probably all seen this kind of scan before. There's a little bit of intraventricular hemorrhage as well in the third ventricle here, and in the lateral ventricle. Of course, it probably came into the lateral ventricle about here. And here's an example, another example of a basal ganglia hemorrhage where the focus is probably in this region, and then the hemorrhage is into the ventricle. There's a large amount of this blood that's actually intraventricular. Here's a hypertensive brainstem hemorrhage. As you can imagine, there's not a whole lot you can do with this other than supportive care, and a lot of these patients don't do very well, although sometimes they surprise us. So what are our management goals, our strategies, our priorities for patients with spontaneous intracerebral or intracranial hemorrhages? And first of all, we have to always remember that airway, breathing, and circulation is still number one. So this stuff is automatic to all of you guys, and you don't want to forget it. ABCs always come first. If you don't get oxygen to the brain, it doesn't matter what else you do. But then after that, preventing rehemorrhage is our number one goal. And the first thing we want to do to prevent rehemorrhage is manage the blood pressure. And you know, we can talk for days about where the ideal place is for the blood pressure in patients with intracranial hemorrhages, but it's going to depend on the patient and the hemorrhage and other conditions. So here I just put, you know, roughly 110 to 140 systolic, but some patients might need to be higher than that. If you've got a known chronic hypertensive who's not compliant on their meds and they come in with a pressure of 220, you probably don't want to drop them that straight down to 110, or they're not going to perfuse very well. On the other hand, if you have a 32-year-old young woman with a spontaneous subarachnoid hemorrhage from a probable aneurysm, that patient you probably really do want to get below 130 or even below 120, because your number one goal is to prevent rehemorrhage through blood pressure management, and she probably doesn't need a blood pressure over 120. And we have switched to using nicardipine in most of these patients. We've certainly used nitrite and sometimes still use labetalol and hydralazine, but often it's best just to jump straight to a drip that's going to give you quick control and smoother regulation of blood pressure. And more, the second option, or second issue here, correcting coagulopathy, is becoming a bigger and bigger concern, because so many patients are coming in on Coumadin with INRs of 3 or 7 or wherever it is that it shouldn't be. And if we don't correct their coagulopathy, the risk of hemorrhage progression is significantly higher, and mortality rate and bad outcome rate is significantly higher for these patients as well. And we really need to get on this as fast as possible. And we've been around the block from fresh frozen plasma to activated factor 7, factor 9 complex, and now we're back looking at, well, do we really want to hit these people as hard as factor 9 complex, or are the thrombotic complications too high? And we need to find a balance for how to correct their coagulopathy, prevent progression of hemorrhage without having unnecessary or undue thromboembolic events. So this is very much a challenge. We all know it takes time to get the fresh frozen plasma cross-matched and thawed into the patient, and we're constantly battling to get this done faster and faster to minimize hemorrhage progression in these patients. And as we're controlling the blood pressure, we always need to be thinking about cerebral perfusion pressure, which, as most of you know, is the mean arterial pressure minus the intracranial pressure. Remember that chronic hypertension, especially untreated hypertension, is going to shift the autoregulation curve to the right, so that patient's tolerance for a low blood pressure is not going to be the same as somebody who doesn't have chronic hypertension. And so we want to control the blood pressure, but also we may need to control elevated intracranial pressure. We'll talk more about that later today, but you can certainly use these modalities that you're familiar with, mannitol, hypertonic saline, hyperventilation carefully, if at all, and ventriculostomy when indicated, and evacuating hematomas if you have a large mass lesion. So now we're going to switch gears and talk more specifically about subarachnoid hemorrhage. And the number one etiology for spontaneous subarachnoid hemorrhage, of course, is ruptured aneurysms. But don't forget that the number one cause for all subarachnoid hemorrhages is actually trauma. But we're talking about spontaneous subarachnoid hemorrhages here. So usually you'll see thick blood in the basal cisterns, particularly in the suprasellar cistern and the sylvian fissures, and even up into the convexity sulci. It's commonly associated with intraventricular hemorrhage as well. A lot of times these patients develop some hydrocephalus as a result of the IVH, or even just from the subarachnoid hemorrhage alone. Sometimes they have intracerebral hemorrhage as well, with parenchymal hemorrhage. And about 80% or more of the aneurysms occur in the anterior circulation, 15 to 20% in the posterior cerebral circulation. And this is really a dangerous disease. The mortality rate is approximately 50% with a ruptured aneurysm. And a lot of those patients die before they ever get to the hospital. The overall mortality rate is around 50%. And then there's a 50% rebleed rate within the first 6 months. This is old data because most patients are treated now, and so we don't really follow people out to 6 months to see how often they rebleed. But 30% of that occurs in the first month, and a lot of it occurs in just the first few days. And there's a 50% mortality again with each rehemorrhage. So this is really a dangerous disease. AVMs can also result in subarachnoid hemorrhage, but they're often associated with parenchymal hemorrhage and sometimes IVH or even subdural hematomas, especially the dural AV fistulas. And oftentimes these patients have some prior history of headaches or seizures. The hemorrhages from AVMs are not quite as deadly as subarachnoid hemorrhages. There's about a 10% mortality rate with each hemorrhage, and only about a 3 to 5% rebleed rate. So these patients are not in the same boat as the subarachnoid hemorrhage patients in terms of having an extremely high risk of rehemorrhage. And so they don't necessarily have to be treated immediately. We don't have to treat the lesion immediately, that is. With an aneurysm, as we'll see, you really do want to secure that aneurysm early to prevent the risk of rehemorrhage. With AVM patients, blood pressure control is really your number one goal, and the lesion itself can often be treated electively after the patient has had some time to recover even, because the rebleed rate is not really high, and it's not that much higher right after the event than it is in the natural history of the disease over time. The mortality rate is also not quite as high, and the symptoms and morbidity, of course, depend on the location and size of the hemorrhage. And then there's this condition that some of you have probably seen and heard us talk about, and that's the non-aneurysmal perimesencephalic subarachnoid hemorrhage. And we'll look at some pictures of these, some CT scans, to differentiate this from the more classic aneurysmal subarachnoid hemorrhage. And in this case, in the classic case of non-aneurysmal perimesencephalic subarachnoid hemorrhage, the hemorrhage is typically limited to the perimesencephalic and prepontine cistern, and usually does not cross into the suprasellar cistern. There's a thick layer of arachnoid, referred to as the membrane of Lilliquist, that separates the interpeduncular cistern and prepontine cistern around the brainstem from the suprasellar cistern. And with an aneurysmal rupture, which is obviously arterial and often from a large arterial source, the hemorrhage just blows right through this arachnoid layer, and it fills the perimesencephalic interpeduncular cistern and blows right into the suprasellar cistern and out into the sylvian fissures and wherever it wants to go, really. But with non-aneurysmal perimesencephalic subarachnoid hemorrhage, the source is probably a rupture of a small vein or a small perforator of the brainstem. And so the hemorrhage is not nearly as violent, and it usually doesn't rupture through the membrane of Lilliquist, so you can distinguish these by the absence of blood in the suprasellar cistern. Sometimes, of course, the rules are broken and the blood will still get to the suprasellar cistern. And the mortality rate for these, this is a completely different disease. The mortality rate is essentially 0. These patients typically do very, very well. The rehemorrhage rate is very, very low, and they have a very good prognosis for a full recovery. The trick is knowing whether you have one of these or an aneurysmal subarachnoid hemorrhage. And because you can't be absolutely certain just from the CT scan, these patients still need to be worked up. They still need to have a CT angiogram, and probably, if that's assuming the CTA is negative, then at least one good catheter angiogram study. And the literature is supported that if you have a classic pattern for perimesencephalic non-aneurysmal subarachnoid hemorrhage, and you have one good negative catheter angiogram, then you probably can stop at that point. You don't have to keep looking. You don't have to re-angio over 2 weeks or 3 months and keep looking for an aneurysm, because it's probably this disease. And then other sundry etiologies for spontaneous SAH include vertebral and carotid artery dissections, which we seem to be seeing more and more of. And we especially see a lot of vertebral artery dissections in amphetamine and cocaine abusers. And much more rarely we see things like spinal AVMs and dural AV fistulas. Occasionally we'll see hemorrhages from mycotic aneurysms, although these are often more parenchymal hemorrhages because they tend to be more distally located aneurysms out of smaller blood vessels, not down on the larger vessels in the circle of Willis. And sickle cell disease. And Dr. Larson can tell you more about marijuana as an emerging cause for spontaneous subarachnoid hemorrhage and marijuana-induced vasculopathy. We're all a lot more familiar with the cocaine and amphetamine-associated vasculopathies, but we're seeing more and more vasculopathy from marijuana use, especially now that we have more medical marijuana dispensaries than Starbucks. And this is a classic pattern for an aneurysmal subarachnoid hemorrhage. We see the classic starburst subarachnoid hemorrhage, or as our nurse practitioner, Mary Sherman, likes to call it, the dead chicken pattern. And you can see this is also extended up into the inner hemispheric fissure here. This is blood around the brainstem. Here's the inner peduncular cistern. You can see that it's also extended into the suprasellar cistern, into the sylvian fissures, into the inner hemispheric fissures. So this is a classic aneurysmal pattern. And this is the classic non-aneurysmal perimesencephalic subarachnoid hemorrhage pattern with blood in the prepontine cistern around the brainstem, but not in the suprasellar cistern. The suprasellar cistern is clear. There's no hemorrhage into the sylvian fissures or the anterior inner hemispheric fissure. So this patient will still need a CT angiogram, and there's still going to be a catheter angiogram if that's negative, but once you've done that much, you can stop. And Dr. Larson, I don't know if you have any comment. Do you agree with that strategy for a pattern of hemorrhage like this? If you had two good negative CTA, negative angiogram, would you feel comfortable stopping with that pattern of hemorrhage?
That's been published in the literature that it's fairly safe to do that, but I think it has to be individualized on the patient and the pattern of hemorrhage.
Right, and you know, just to back up and to think about the workup, we see approximately 10% of subarachnoid hemorrhages, even with this classic aneurysmal pattern, that are angiogram negative, and then we never find a source. But the difference is, if the CTA is negative on this one, you can bet we're going to be going to catheter angiography very soon thereafter. And if that's negative, we're going to be repeating the catheter angiogram in approximately a week or sometimes even less. And if that's negative, the patient's probably still going to get a third catheter angiogram in several weeks or a couple of months, because this is such a suspicious pattern that we just don't stop looking until we're absolutely sure there's not an aneurysm hiding. Sometimes they're partially thrombosed and we can't see them. Sometimes there's vasospasm that precludes the the flow into the aneurysm and makes them hard to see on angiography. So with this pattern, we're just going to keep looking vigilantly and at a pretty high rate with this follow-up angiogram pretty early. With this pattern, on the other hand, if the CTA is negative, we might even wait a couple of days before we do the catheter angiogram to space it out a little bit and see if anything changes. Whereas the other one, we're going to be doing it right after the negative CT angio. And then just to be complete, this is the classic traumatic subarachnoid hemorrhage, which is typically more in the convexity region. We'll see a little blood in the convexity sulci. It could be unilateral or bilateral. But the basal cisterns, the suprasellar cistern, the perimesencephalic cisterns, are all clear. There's no subarachnoid hemorrhage around the brainstem, around the cervical willis. And obviously, you'd like to have a history of trauma to be comfortable that this is a traumatic subarachnoid hemorrhage. If you have no history of trauma, this could be the type of pattern you might see with a drug-induced vasculopathy, like a marijuana-induced subarachnoid hemorrhage can have this pattern with convexity subarachnoid hemorrhage and no blood in the basal cisterns. So you have to be thinking about the history in addition to the appearance on the CT scan. So what are our goals in the management of a patient with an acute spontaneous subarachnoid hemorrhage, particularly the aneurysmal pattern? And the number one goal, again, is to prevent rehemorrhage. The other things that we have to worry about, though, is treating hydrocephalus if it's present, and diagnosing and managing vasospasm. And whenever I'm having a discussion with the patient or the families, I always like to think of these three things. I like to warn the families that these are the three things we're going to be thinking about, that we're going to be worrying about over the next several weeks. And because as you guys know, these patients are usually in the ICU for 2 to 3 weeks, and this stuff continues to come up over time. So I kind of prepare for it. I say we've got 3 things to worry about. We've got the aneurysm itself. We've got to prevent rehemorrhage. That's our first and primary goal. Keep this thing from happening again. Then we have to be looking out for hydrocephalus and worried, does the patient need a ventriculostomy or not? Are they going to need a shunt later down the road? And then the third issue is vasospasm, which tends to come up a little bit later. The time frame for the onset of vasospasm is usually after 3 days from the day of the subarachnoid hemorrhage, with the peak onset around 5 to 7 days post-hemorrhage. So it's something that's coming up down the road, but I like to prepare the patients and the families for that so they'll know why we're going to hold them hostage in the ICU for 2 to 3 weeks and wake them up every single hour all night long until they're completely psychotic. So the first and most important thing is to prevent rehemorrhage. And back to the number one issue we just harp on over and over and over again, managing the blood pressure is absolutely the most important first step in these patients. And this is where everybody can help and where everybody needs to be thinking about it. And so we have to control these patients' blood pressure. They need hard line. They need nicardipine if their blood pressure is not easily managed with a few doses of labetalol or hydralazine. And we need absolute constant blood pressure management. Their blood pressure has to be kept less than 140, and usually more ideally less than 130 to prevent rehemorrhage while we're working them up, getting the CT angiogram, getting the catheter angiogram, determining what the best treatment is, and getting the aneurysm secured. If they have a coagulopathy, obviously we need to correct that coagulopathy and we need to do it quickly. And then ultimately, the best way to prevent rehemorrhage, of course, is to occlude the aneurysm. And so once we find the aneurysm, we study its size, its location, its morphology, and we try to determine whether that aneurysm is going to best be treated with craniotomy and clip ligation or with intravascular coil occlusion or embolization. And fortunately here we have neurosurgeons and neurointerventionists. We work together in a very comprehensive and collegial manner to study these patients, look at the films, figure out what is the best treatment option for these patients so that we can optimize their care and treat them expeditiously. Hydrocephalus is pretty straightforward. If the patient has hydrocephalus initially, we like to get a ventriculostomy in early, often the night that they come in, or perhaps the next morning. Sometimes they'll develop it a little bit later. They have to be treated further down the road, but it's often present on the initial CT scan or the follow-up in the next morning. If the patient is going to be going for endovascular therapy, we usually like to get the ventriculostomy in before they go to the angio suite, especially if there's any chance that they might need any anticoagulation therapy. We'd like to have that ventric in before they get their anticoagulation. And if possible, ideally put it in the night before, let it settle, if you will, for a few hours overnight before they go to angio the next morning, in case they end up needing anticoagulation. Now, the use of intraventricular TPA is quite controversial, and we don't use it very often, but every once in a while we find that it is a useful adjunct for managing patients with really thick, dense cast of hemorrhage in their ventricles. If their ventricles are really clogged up with blood, and we just can't manage their hydrocephalus or manage their intracranial pressure with ventriculostomy alone, if the blood's not clearing, then oftentimes we use intraventricular TPA to clear the hemorrhage out of the ventricles. The ideal time to use this is in a setting where you have not only identified the source of the hemorrhage, but treated it. So if you have an aneurysmal subracular and intraventricular hemorrhage, and that aneurysm is clipped or coiled, then you presumably have taken care of the source of the hemorrhage, and so it's a little bit safer to use intraventricular TPA. It's still very risky, but a little bit safer if the bleeding source is protected. In spontaneous ICHs with IVH, it's a little bit riskier because you've got a hypertensive hemorrhage, you don't have protection of your bleeding source, and so we're even more nervous to use intraventricular TPA in the setting of spontaneous ICH. But with aneurysmal hemorrhage, if the source is protected, then we're a little more comfortable using it. We still use it very rarely, though. And then finally, if we can't manage the patients, or if the patient doesn't learn to manage their own CSF circulation after a week or two or three of a ventriculostomy, if we can't wean them off the ventric, or we take out the ventric and they develop hydrocephalus later, then they may end up needing a VP shunt. And in some series, up to a third of the patients with subaqueous hemorrhage end up needing VP shunts. I think in our population it's a little bit lower than that, but it's still closer to a third. Then this is really where the nuts and bolts of ICU neurocritical care management for these patients comes in. I'm not going to talk a whole lot about this because Dr. Larson has a whole presentation on the management of vasospasm, but I'll just introduce the idea here that we really have to watch these patients carefully and treat them very cautiously and aggressively so we prevent delayed ischemic events, strokes, basically. These patients will go into vasospasm, literally have a stroke, and as Dr. Copeland inferred earlier, the patient can be looking absolutely perfect after the treatment of their aneurysm, sitting up, reading the morning paper, eating their Cheerios, looking like they're ready to go home, and an hour later they can be hemiplegic and aphasic from vasospasm. It can be absolutely devastating. So we have to be very, very vigilant with these patients. And so we start with what we call vasospasm watch, or vasospasm prophylaxis and monitoring. So this is what we want to do to watch for vasospasm and to try to minimize the risk of a delayed ischemic event. So we watch the patients visually, neuro checks every hour. This is where neuro ICU nursing is paramount. This is absolutely the most important part of the vasospasm watch, is the neuro checks. The bedside nursing care is the most important management of these patients. You guys can do more for these patients than we can ever do for them. And so you have to be absolutely vigilant and watch for neuro changes. We use the Motorpedic for prophylaxis, and there obviously been studies that show decreased incidence of delayed ischemic events and improved outcome with the use of the Motorpedic. is still a little bit controversial about exactly how that works and whether it really works, or does it just force us to push harder with our hyperdynamic therapy because the lidocaine drops the blood pressure and we push even harder. But we use it, and the protocol calls for 21 days of lidocaine. Occasionally, we will cut that short in patients that are doing really, really well and maybe ready to go home in less than 21 days.